Hello, I'm Andrew Kaunitz, Professor and Associate Chairman in the Department of Obstetrics and Gynecology at University of Florida College of Medicine in Jacksonville. Today I'd like to discuss use of combination estrogen-progestin therapy in menopausal patients. And specifically, I'd like to focus on which progestin may be safest in terms of breast cancer risk. In my practice, and likely in yours, women's chief concern regarding the safety of menopausal hormone therapy relates to the possibility of an increased risk of breast cancer. We know from the randomized controlled trial of women with a uterus in Women's Health Initiative that use of estrogen-progestin or combination hormone therapy is indeed associated with a modest increased risk of breast cancer after 5 years or more of combination estrogen-progestin therapy. This relative risk of approximately 1.26 or a 26% elevated risk of breast cancer with long-term use of estrogen-progestin therapy, I explain to my patients, is comparable to the equivalent modest increased risk of breast cancer associated with moderate alcohol consumption, such as 2 glasses of wine each evening. I also explain to candidates for menopausal hormone therapy in my practice that for women 10 years or less following the onset of menopause, or women in their 50s, use of menopausal hormone therapy is associated with a reduced risk of coronary artery disease. We don't have data from randomized trials which informs us regarding what's the safest progestin to use in women with a uterus contemplating combination hormone therapy. However, we do have important recently published observational studies from Europe which have looked at the specific progestins used in combination hormone therapy and risk of breast cancer. Specifically, recent reports from Germany and France suggest that combination hormone therapy with progesterone is safer from the perspective of breast cancer risk than combination hormone therapy using the progestins norethindrome acetate or levonorgestrel. Recall that in my previous video blog, I discussed the safety of oral versus transdermal estrogen therapy and concluded that transdermal estrogen therapy appears to be associated with less risk of venous thrombosis than oral progestin therapy. And therefore, in my practice, first-line estrogen therapy, my preferred route, is transdermal. For similar reasons, in my practice, my first-line approach to combination estrogen-progestin therapy is to combine transdermal estrogen, because it appears safer in terms of thrombosis risk, with micronized progesterone, which appears safer in terms of breast cancer risk. The appropriate formulation is micronized progesterone, and if it's used continuously, it would be 100 milligrams orally every night. If it's used cyclically for 12 days or more each month, it should be prescribed in the 200 milligram formulation. And because micronized progesterone contains peanut oil, it should not be prescribed to women with a history of peanut allergy. Someday I hope we'll have randomized controlled data clarifying which progestin is the safest. But right now we have good observational data upon which we can base our prescribing and counseling decisions for our patients. My preference based on the available data is to prescribe transdermal estrogen from the perspective of an apparently lower risk of thrombosis, and micronized progesterone, which apparently is associated with a lower risk of breast cancer than other progestins. Thank you.